Thank you for staying with us. This is Good Morning Kenya, and my name is Vivian Dagwa. Now, today being a Tuesday, you definitely know that it is Health Tuesday. And on Health Tuesday, we will be looking at heart diseases and some of the solutions to it. What are some of the most common cardiovascular diseases we have in the country? What are the causes to this? What are some of the treatment options? And what are some of the early signs and symptoms that you should look out for? Now, here to walk us through this particular conversation and just let us in on everything we need to know concerning this topic is Dr. Keith Ndindi, who is a consultant cardiothoracic surgeon. Thank you so much for creating time for us. How are you doing this morning?
Very fine, thank you, and thank you for having me.
If I may just go straight into what are some of the most common heart diseases in the country?
I'd like us to pan out maybe for just a moment, look at it from a helicopter overview of what we call cardiovascular diseases. Generally speaking, we have communicable and non-communicable diseases. And when you come to non-communicable diseases, we're really talking about cancers and cardiovascular disease. So when we thin down to cardiovascular disease, it is in that perspective of looking at generally what the health problems that Kenyans face. So when you talk about cardiovascular diseases, there are diseases of the heart, those are the cardiac diseases, but you also have vascular diseases. Those are diseases of the veins and arteries. These are the vessels that carry blood away from the heart and to the heart. But I think today we're really going to be talking about diseases of the heart itself.
Yeah.
And when you're talking about diseases of the heart itself, there are categories that I would like to just let our viewers know about. The diseases that generally affect the younger population. Mainly these are congenital heart diseases, meaning these are people that are born with these heart problems. And then there are acquired heart diseases that generally affect the older population. And here we talk about coronary artery disease, there's rheumatic artery disease, things like infectious endocarditis. So generally when you're talking about heart disease, those are the groupings that we like to let our people know.
All right, so the common ones that you've dealt with in the country are the ones that you've mentioned?
Yes. I think really one of the commonest is congenital heart disease. These are problems that children are born with. Usually, colloquially, we hear people saying someone was born with a hole in the heart.
Yes.
So that is quite common. But here in Kenya, like just in the rest of Africa, we've got something that we call rheumatic heart disease, which is an acquired disease of the heart that is really common amongst people with poor socioeconomic status. It is the cause of lots of cardiac death. But beyond that, in the older population, we've got something that we call coronary artery disease. This is really a lifestyle illness that affects the small vessels that supply the muscle of the heart. And they cause things like heart attack and many deaths.
All right. So what are the causes to some of these heart diseases that you've just mentioned?
Probably I'll start with the coronary artery disease that affects people that are a little older. In Kenya, though, we are seeing it in much younger populations. And as I mentioned, this is really a lifestyle illness, meaning that a lot of it is contributed by the foods that we eat. And as you know, we've slowly been shifting from what we call our traditional type of meals. We're doing more of Western type diets that are full of sugar, fats, and that is really causing a problem. The other thing is that we are not moving as much as we used to. These days, even Mama Mboga goes to the market on a boda. We used to walk quite a bit, but that doesn't happen anymore. So poor diet, lack of proper movement, what we like to call exercise. Here in Nairobi, I see people, you come from your house in the morning, maybe you live on a 7th floor, you get on a lift down to ground floor, you get on your car, then you get in the office and you're seated most of the day. So people are not moving as much. And so these are what we call lifestyle diseases. But most importantly, smoking. Coronary artery disease, smoking really contributes a huge deal. So though there is genetic risk, when you think about the lifestyle aspects that are actually controllable, those are the ones that really push people over. And then you start to have manifestations of coronary artery disease. When you talk about rheumatic heart disease, which is really common amongst the younger population. So in Kenya, most of the probably people between ages 10 to their early 20s. We see many of them having rheumatic heart disease, which is the result of an infection, a throat infection that's not controlled properly, then later on manifests as rheumatic heart disease. Then the congenital diseases that, for people who are born with, sometimes they're associated with certain nutritional deficiencies in the mother, lack of proper prenatal care, or sometimes it just happens, we don't know why, but then kids get born with congenital heart disease.
Yeah, I want to get back into what you just talked about, the fact that some of these diseases, we now see them in the younger aged population rather than, back then it was a disease, quote unquote, for the older generation. What exactly should we avoid eating, and what should we eat? Because you've said mainly it's because of the lifestyle. We're not walking as much. We're eating the wrong food. So what are these wrong foods that you're talking about, and what should we be eating?
When we break it down to the detail, they usually say the devil is in the detail. So it's important to think about it from a sugar perspective. Really the thing driving cardiovascular disease, not just in Kenya, but across the world, is sugar. And more specifically, what we call refined sugar, the simple sugars. And so table sugar that we add this day to everything that we are drinking. If you take even the juice that is sold in our supermarkets, lots of it is made of sugar. The soft drinks, I will not mention them by name, but just generally soft drinks that we use. And even there are secret added sugars, like the sauce that we use on the tables, it still has sugar. So we are consuming a lot of sugar. And the result of that is that we get bigger. So the obesity that we see is really driven by the sugar that we consume. One of the things that I noticed recently, even in church, our church, we have got kids that go for Sunday school, then they're given snacks thereafter. But what snacks are they getting? Again, purely simple sugars. So from an early age, we are beginning to change the way our kids look at this thing called good food. So good food is seen to be everything that is full of sugar. And so they grow with that, and then we are getting a population that then is bigger, so obesity is now a problem, not just in adults. We are literally having a crisis of childhood obesity. And with that comes higher levels of cholesterol in the body, and then the blood vessels pay the ultimate price. Because when cholesterol accumulates in the body, it blocks blood vessels, and then you now get coronary artery disease.
What maybe are some of the alternatives to something like table sugar? Is honey a better option to that?
It's actually not. A lot of people say that honey is natural sugar.
Yeah, it's organic, we thought.
It's organic, but even table sugar is organic. At the end of the day, if you break it down to the molecules that actually make sugar, it's the same thing. What I would advise, though, there are foods that comprise of complex sugars, and a lot of what our older folks, the parents, grandparents used to take, things like the cassavas, the arrowroots, the sweet potatoes, they're made of more complex starch that once you take in the body, it takes a process to be broken down, and it's not absorbed quickly as simple sugar. So those are the better alternatives to have. And really, this idea of meals in between the day, so the idea of just, I've seen even when you go for conferences, the little sweets that are placed on table. So it's like we are always feeding. We become like the animals in the farm that even through the night they're just chewing the cud. But then we are doing that with sugar, and so we're just consuming too much sugar. I think there's a concept that is called mindful eating, where you're getting a good meal in the morning. Most of it being complex sugar, most of it being proteins, quite a good chunk of vegetables, and then try to eat spaced out, morning, lunchtime, and in the evening. Really, this idea of meals in between the day does not help at all.
Yeah, I'm really surprised that honey is not a better option to this, because most of us, I'll speak for myself, I thought honey is the way to go. Like, I don't take sugar in my tea, but I put honey, and I thought honey is actually the way to go.
It is not.
So what should we alternate that with, or we just go sugarless?
if you can reduce the amount of sugar you're taking, so I know for many people it's difficult to go cold turkey, but if you can gradually reduce until a point where you actually don't need it anymore, that is the best way. And it's possible, it's doable. Literally, if I add now sugar to my tea, it's nauseating. So I think if you just start slowly, sometimes people take 4, like I used to take almost 4 teaspoons in my cup. Then slowly reduce that over time to a point where you really don't need to add in any more sugar. That's the way to go.
Okay, thank you for that. Now let's come to the oils that we take. You know, are there good oils and bad oils when it comes to cooking oils?
Yes, and the nutritionists will tell this to us in greater details. But there's a concept that we call the trans fats that are made in. If you look at the solid fats that are sold out there, the principle behind them is really the trans fats, and we try to avoid as much as possible. But if you can get your fats from things like avocado, these are natural fats, the better. And if you can reduce the amount of fats in the meals, fat actually, in terms of when you look at the food groupings, carbohydrates, fats, and proteins, fats have got the highest concentration of calories, even more than what you find in carbohydrates. So when you're using fats, it's not bad to use them, but use them in moderation. So it is important to think about that, so that the meal that you have wholesomely, you're thinking, what is the caloric burden that this meal is giving me? But more importantly, I think beyond just what we eat, is to think about the amount that we eat. And many people are not thoughtful about it, especially when they do it a lot. So you're just spreading many meals along the day, and you discover by the end of the day you've taken so much. Many people now are getting into probably eating 1 meal a day. The people who are doing even intermittent fasting. We're realizing that you don't have to always eat. It's good to give your body a rest. It's not a bad idea.
All right, before I get into now some of the symptoms and the preventable ways, that is the treatment options for some of these diseases, I want to finish up on the diets, if you may allow me. Are we supposed to consume less dairy? Because I've had a debate on, you know, dairy is bad and so forth. So are we supposed to consume less of it?
The debate will rage on for a long time, because even we in the medical community, there are those who would really advocate for no dairy. I know, for example, Africans generally have got higher levels of lactose intolerance. So there are many of us, as we grow a bit older, we find when you take milk, you start having bloating and problems like that. So lactose intolerance is a big problem, and if you're in that group, then you avoid it. But generally speaking, there's no problem with dairy in your diet. In fact, there are communities that like the more sour version, so they keep the milk, and mursik is a delicacy in many places. Where I come from, people really love mursik, so we can use it. But think about it wholesomely, because it's part of the caloric math that is part of your meal. So milk still has calories. So when you're having your meal, you're thinking about it wholesomely, including just how much is that bringing in. But even we in the medical community are not convinced one way or the other.
About dairy? About
milk, yes.
Okay, let's get into the symptoms. What are some of the early signs and symptoms of a heart problem?
I think I'll probably look at them as 2 separate groupings. So let me start first with the children, because I think we miss diagnosis in children a lot. And so most kids, by the time the right diagnosis is being made, it's too late for them to even get surgery or medication that will save their lives. In fact, I was inspired to get into heart surgery because I lost a friend, a high school mate. He was diagnosed very late, and by the time they were discovering he had a problem, it was just too late, and he passed on. And that is how I got inspired to even get into heart medicine, and specifically now to get into heart surgery. So when you're talking about kids, it is important for mothers to deliver in health institutions, because sometimes congenital heart problems are picked when the children are examined just after birth. So if these children are born in settings where there's no medical professional who can actually examine the kids, it's very possible to miss critical heart lesions that would otherwise be picked up and sorted out early. So that is number one. But number two, there are certain problems that children start having. Their kids, for example, the mothers notice when the child is breastfeeding, is sweating a lot, is having difficulty in breathing while breastfeeding. And this is not normal. And many times, that is the very first clue that there is a problem. So if you notice that your child seems to be sweating a lot, struggling to breathe as the child breastfeeds, it's important to have these children checked out. The other thing is just the way the children are growing. Many times, if a child has a heart problem, their rate of growth is not the same as the rate of growth of the normal children. So we usually generally refer to it as failure to thrive. A kid is just not growing like the rest. So it's good for children like those to be checked. But finally, you can have children having, other kids are running, and this kid just seems to be falling off the pace. And many times parents think maybe my child is just a little slower than the others. But if your child really is not keeping up with the rest, they always want to rest, then it's good for them to be checked out. And then lastly, one of the most common congenital heart problems we have in Kenya is called tetralogy of Fallot. And the way these kids usually behave, they like to squat all the time. And that squatting, there's something scientifically I'll not care to explain, but that squatting actually helps them. And so these kids naturally want to squat now and again.
What age are we talking about when you say kids?
So these are kids who are probably between the ages of 2 to 10.
Okay.
And you notice that when they start feeling breathless or feeling tired, they want to get down and squat. And there's something that squatting actually does in terms of their cardiovascular system to increase what we call peripheral resistance. So when you notice those things in a child, it is important for those children to be checked out. And then when they are checked out, we're able to pick these lesions early. So difficulty in breathing, excessive tiredness, that's squatting. Sometimes there's some discoloration like bluish lips or tongue, meaning not enough oxygen is going to the tissues. Again, that can be a clue that there is a particular problem, congenital problem that this child is having.
Okay, that's in children now.
So that is in children. And it is important to think about it that way, that in children they might present a little different. But in adults, because most of the time what we're dealing with in older adults is coronary artery disease, the presentation would be a little different. The most dramatic presentation is something that we call angina, which is pain that is caused by heart muscle not getting enough blood supply. So it is the classic, somebody feels a lot of pain in the chest. Usually on the left side, it moves, or we call it radiating to the jaw or left arm. Classically, that's how it presents. So we call that anginal pain. And that is an ominous sign. If you're having pain of that nature, that is not something that should be ignored.
So that's pain that starts on the left side of the heart going up, or could it just be pain from here going down?
Sometimes it presents in an atypical manner. So especially for people who have diabetes and more so in ladies actually. So it might not present with classically, we call it like crushing pain. Literally you feel like there's some weight on your chest that is crushing the chest, and that chest tightness and pain that radiates to that left side. Once you have that, that is something that really should be checked out in a proper health facility. So that typical anginal presentation, when we have that, we start thinking, could there be coronary artery disease? In fact, the way I look at it, I assume there is a coronary artery disease until proved otherwise. It could be other things. It could be pneumonia or problems with the gastrointestinal tract. But when you miss a heart problem, the results are many times fatal. So it's better to assume the worst, get proper checkup. Then the other way in which these heart conditions can present, even in adults, is just that difficulty in breathing, excessive.
I'll ask you to hold that thought, Doc.
Sure.
If you allow me, we take a short break and then we'll be back and you continue telling us some of these early signs that you can get to catch before it's too late.
Abantu ba Minto Mbuyamole.
Your favorite KBC station, Minto FM, is now at your doorstep. Enjoy the hottest KBC music, informative and entertaining shows, and reliable news only on Minto FM. Tune in to Minto FM on 91.7 FM in Nyamira, Kisii, and its environs.
Minto FM,
One year in office, 23 ministries. Time to review the journey in implementing the bottom-up economic transformation agenda. What is your assessment of the government's performance? Will they ace the performance test? Tune in to KBC News at 9 p.m. for the government scorecard.
Hayawi huwa Rais aliweka ahadi ya kwamba ataleta universal health coverage. Nataka kualika tarehe 20 mwezi wa 10 kule Kericho County. Mje tujumuike pamoja na Wakenya wote kuhakikisha ya kwamba hii universal health coverage inakuwa launched. Karibuni sana.
Welcome back to Good Morning Kenya. In case you're just joining us, this is Health Tuesday and we are talking about heart diseases and their solutions. Before we went for that break, Doc, you were just getting me into some of the symptoms when it comes to adults.
Yes. So as I mentioned, angina pain is probably the one that we bothers us the most. And it's important to emphasize that, because once it's missed or misdiagnosed, patients die.
Yeah.
And so that's really important. But the other way in which patients present is still difficulty in breathing. So you find probably you run up the stairs, but then you start having difficulty to run up the stairs. You're catching your breath after 2-3 steps. You have to literally rest before you keep going. So you are like, what's going on? In fact, just recently I had one of my good friends who really loves going to the gym, and he just noticed the things that he would be doing easily. Now he has to, in between sets, he has to rest a little longer. And that was the first clue that let him know that there's a problem. But the other way in which patients like this present, sometimes it is in terms of other peripheral manifestations, meaning because the heart is not supplying excuse me, good blood flow to peripheral, those are tissues, that the legs, the peripheral tissues, then patient starts to have problems. Remember, the heart really is like the engine of the body. If there's a problem with the heart, then you start to have symptoms everywhere else, because the heart is just not supplying sufficient blood to even peripheral tissues. So generally, angina pain or breathlessness, excessive tiredness. Sometimes even adults notice that bluish discoloration because there's some congenital diseases that become worse as someone grows older. So we call these congenital diseases in the adult population. So sometimes you start noticing some bluish discoloration. There's something that we call clubbing of nails, meaning there's a roundness of the nail bed that someone starts to have. All these show that the body, the oxygen levels in the body have generally been low. So those are important.
Sorry for that. When you say a roundness on the nails, what exactly do you mean? What are we looking at?
So there's something called finger clubbing. So literally the tips of the fingers start to look like small clubs.
The fingers, not the nails?
The nail, the part of the fingers that has got the nail bed. So it starts literally to look like a little club.
Okay.
I wish I could have a picture to show that. Our viewers can check out finger clubbing. And it's one of the things that shows that for a long time, the body has not been having good oxygen supply to the peripheral tissues. So we call it chronic cyanosis, and it presents with that finger clubbing.
Okay.
Yes.
So those are the early signs. And how long can one go undetected? How long can I go maybe as a person without me experiencing any problems, yet I have a heart condition?
So a lot depends with the nature of heart problem. For example, in the congenital group, there are two major classifications. There's a group that we call cyanotic heart problems, meaning the concentration of oxygen in the blood is going to be very low. So these tend to be picked up earlier. But the other problems that we call acyanotic, meaning the concentration of oxygen in the blood still remains normal, and so this can stay for quite a while. In fact, there are some people that we pick their congenital problems in their 30s, in their 40s, but then there are certain complications that will have been occurring slowly, and by the time we diagnose someone, then even the medication or the surgical treatment or options are limited because it's too late. Yeah, but for the older group of people, usually the older patients, once somebody has coronary artery disease, there are many options when you're talking about how we can manage them treatment-wise.
Yeah, so the way to go is to go for regular checkups.
Exactly.
Even if I'm just doing okay, I should go to hospital and get checked.
Yes, and I know we in Africa generally, because I've worked in Africa and I've worked in a Western country. Our health-seeking behavior is really strange. Sometimes maybe it's fueled by economic factors, but even people who are well-to-do, generally we don't like checkup. There are people who only come to hospital when they are not feeling well. And the problem with that is that the early detection then becomes a mirage. And for many of these heart problems, you can only get cure when the detection is made in good time. So it is really important to have a culture of seeking, not just treatment, but just well-being. How am I doing, doctor? So those annual checkups, the blood parameters that we measure, the blood pressure, the ECG, all those things are really important in detecting these illnesses in good time.
Okay. Can someone with an already existing heart disease, can it be reversed just by food? Is it possible to be reversed by food if they now get into a strict diet and eat properly? Can it be reversed?
So I think what you're referring to probably is more towards the coronary artery disease.
Yeah.
And two things. One, it cannot be reversed by changing diet. But more importantly, progression can be stopped. And that is a good news. You might not be able to change completely in terms of the damage that has already happened, but you prevent it from then progressing to a more advanced stage. So when you're talking about coronary artery disease, there's blockage of the vessels that supply the heart. And that blockage, you usually measure it in terms of percentage. And you start to have symptoms when it's more than 50% blocked. So if you get it early and you change your diet, there are certain medications that are given, you stop smoking, handle the blood pressure properly, then you can prevent progression. So that then you just have checkups now and again to ensure that nothing is progressing. And that prevention of progression is good enough for many people. Once it goes to a certain extent, the blockage goes to a certain extent, then it means the only way to sort that is either the cardiologist putting in a stent in that heart vessel, or we cardiac surgeons coming in and doing a coronary bypass to bypass the place that has a problem. So there is a role for lifestyle change, for prevention generally, but even if you already have the disease, it helps in terms of stopping progression.
All right. You've mentioned smoking as one of the risk factors. Maybe if you can get us through more of these risk factors.
So I'd like to emphasize smoking really, especially because I see a lot of young people beginning to smoke out of, peer pressure. Some
just
people
for the
think,
sake of it.
Yeah, think it's a cool thing. But smoking is bad. In all ways, it's not just coronary artery disease. There are cancers linked to it. In fact, it's the commonest cause for lung cancer. There are many problems that have to do with smoking. So smoking cessation is really critical. Then management of certain lifestyle diseases. So hypertension, a lot of people don't take their blood pressure medications. They've been told they have hypertension, but because you don't feel anything, you just feel, I will not take my meds today. But uncontrolled hypertension is one of the key risk factors for coronary artery disease. Then high cholesterol levels in the body, so we call it hyperlipidemia. So there are a lot of lipids, cholesterols, and the bad type of cholesterols in the body. And there are things you can do to reduce your cholesterols in the body. And then lack of exercise. And these are all controllable issues. You can literally change your lifestyle and start to exercise a little more. What we cannot do anything about is genetic risk. Because we are all born with certain genetics, and you can do nothing about that. But we usually like to say the genetics might load the gun, but your lifestyle pulls the trigger. So you do things, you control the things you can. So you can move more, you can eat better, you can stop smoking, you can control your hypertension, and all this will help reduce the chances of getting coronary artery disease.
So there are heart problems that are hereditary?
Yes. Yeah, so by that we mean there are people that have genetic susceptibility. You just have a higher chance of getting these problems than the general population. So those are factors we can do nothing about. So we for example, know there are certain regions in the world where they have much more coronary artery disease and at a much younger age and a more severe form. That is just genetics. You can do nothing about that. But you can control your lifestyle so that either you delay the coronary artery disease or even prevent it altogether through lifestyle modification.
So is high blood pressure a heart condition? Is it really?
So we don't call it a heart condition, but it is one of the complications that will lead to coronary artery disease. So generally, hypertension as a disease entity in itself does only cause trouble to the heart. So people will get kidney failure because of hypertension. In fact, it's one of the commonest causes of kidney issues. People will get even peripheral vascular issues because of hypertension. People will get stroke in the brain. They get a bleed because of hypertension. So hypertension is a big topic on its own, but it's one of the main problems that leads to coronary artery problems.
Okay. When we talk about a normal pulse rate, what are we talking about?
So we like to say 70, but generally speaking, the pulse rate is affected by many other factors. So children's heart rate is much faster, and that is why for someone a neonate or a child who's below 1, the targets for heart rate are different than those for an adult. And then for people who are more conditioned, so like athletes, if you were to measure Kipchoge's heart rate, you might find it is in the 40s, and that's normal. My wife is a very passionate fitness guru, and her normal heart rate is usually 40 to 45. That's just like normal resting heart rate. So a lot of it depends with how active generally you are, how fit you are. The more fitter you are, the more efficient your heart is, meaning it doesn't have to pump so fast to get the job done.
So there's no specific pulse rate. It depends with an individual and how maybe fit they are. That's what you're saying?
Exactly. But it's important still to note, heart rates below 40, unless in very highly conditioned athletes, generally heart rates below 40, we'll call that bradycardia or low heart rate, and usually they need to be investigated.
What causes that? Low pulse rate.
So just going back maybe to a little biology for our viewers, the heart has got something that we call a sinoatrial node, or the natural pacemaker. So this is a part of the heart that decides or sets the pace for how frequent the heart will be beating. So it sets the heart rate. So there are certain problems you can have on that particular sinoatrial node that affect the way your heart beats, or there can be a blockage along those pathways. So there's a system we call the conduction pathway of the heart. That is how this sinoatrial node sends its impulses to the beating muscle. So if there are blockages at any level, we call those heart block. So there's type 1 heart block, type 2, type 3, and depending on how bad the heart block is, sometimes we literally have to put in an artificial pacemaker to help the heart beat a little faster. So those are the parameters around heart rate.
And when exactly do you as a cardiologist opt for a pacemaker? Is there a particular stage to it that you decide, okay, this person really needs an artificial pacemaker?
True.
To what extent? To what extent, rather?
So we, for patients who have got third-degree heart block, so the way God made us, we've got two chambers on top. We call them the atria, the right and left atrium, and we've got the ventricles at the bottom, the right and left, and they're meant to beat in concert. So why it is important for those to beat in concert is that when the atria empty into the ventricles should be relaxing to receive that, and then the ventricles squeeze. So it's meant to be that normal concert. But you can have points where there is asynchrony. So the way the atria are doing their thing is different from the way the ventricles are doing their thing. So when there's no communication at all, we call that third-degree heart block. And for those, patients need a pacemaker. There are other patients who might have a type of second-degree heart block with very low heart rates, that these also need pacemakers, and usually it's based on the symptoms the patients are having. Literally, there are some people who, on just waking up and walking around, they pass out because the heart is beating too slowly. So again, when patients have those kind of symptoms, we call it syncope, then they need a pacemaker, just an artificial pacemaker that we put in, kind of to set a new pace for the heart.
So a surgery is done and they put it in. Yeah,
it is. It is not a major procedure. There's a way we do it. That is a minor procedure, just under local anesthetic, and then we put in the pacemaker.
Okay, there's someone I know who has a kidney problem. They're undergoing dialysis, and every time they are on the dialysis machine, their heart rate their pulse rate completely goes down under 40, as low as 33. What could be the reason, and would you advise that person to go for a pacemaker? Someone who's on dialysis as well.
So when someone's heart rate goes low, there's something important that we usually do. There's a test we call the ECG. So the ECG is just a tracing. It stands for electrocardiogram, and it's a tracing of the natural electrical current that the heart that is going through the heart. So that ECG tracing usually is the one that helps us know the type of heart block the patient is having. So we can literally be able to look at and say this is first degree, second degree, third degree, based on the ECG. So I would say if somebody has those problems, it's important to get that ECG done. Even during the dialysis, it's possible to get a real-time tracing, so that with that, we're able to know, does this person need some kind of intervention or not? There are many other things, like there are things we call electrolytes that can determine how fast the heart is beating, especially in someone who's getting dialysis. So those are other things that are usually checked that are equally important.
Okay. Now, 4 to 5 cardiovascular deaths are due to heart attack and stroke. If we can just get a bit into heart attack, what are the maybe early signs of someone who's about to get a heart attack, if they're there, and what exactly causes a heart attack or stroke? These are two different things, right?
Yes.
So if you can just get a bit into that.
So let me first talk about stroke so that we get it out of the way.
Okay.
So when you're talking about cardiovascular disease generally, it includes stroke, which is now vessels in the brain. So cerebrovascular disease is part of the bigger animal that we call cardiovascular disease. And so if somebody gets a bleed in the brain, then they get the manifestations of that is what we call a stroke. And it goes back to the hypertension that we were talking about, because most people get a stroke because of uncontrolled hypertension. I feel this is so critical for the viewers to know. If you've been diagnosed before to have high blood pressure, even if you're feeling okay, it is important to consistently take your pressure medication and to consistently get your blood pressure measured. Because if it goes uncontrolled and you get a stroke, the repercussions are so bad. And I've seen it many, many times.
Yeah.
But now, coming back to what classically is called heart attack, when people think of a heart attack, it's that scenario where somebody gets sudden chest pain and they collapse. It's because of an acute I say acute because someone might have been having a coronary artery problem for a long time, but a scenario can occur where there is an acute blockage and there's very little or no blood flow that goes to certain muscles of the heart. And those muscles of the heart can actually die. We call that a myocardial infarction.
Yeah.
So when someone is having that syndrome, the first thing that people see, people generally call it heart attack, in quotes, but that just means there is a section of heart muscle that acutely is not getting blood supply. So it presents with pain, and the worst bit is somebody can actually get terrible heart failure because of that, and that muscle might never recover, and that is how people die because of coronary artery disease. Two quick things I'd like to mention here. If we as the public learn how to recognize some of these symptoms early, it is possible to save some lives. Because somebody might collapse at home, they're clutching on their chest, they're saying they're feeling this pain.
Yeah.
It is important that those people are rushed to a facility that is equipped with both personnel and equipment to sort heart problems. Because we've had even prominent people in our country dying because of coronary artery disease, because it's not recognized early, and people are taken round in circles before being taken to a proper facility that has the ability to take care of these people. Healthcare in our country, there are certain levels. We have level 5 and level 6 facilities. These are the facilities that have got the cardiologists, they've got cardiac surgeons, and they've got equipment that can be able to help people like those. So if you take this person to a level 1 or level 2, we'll have wasted opportunity for intervention. And that is why it is critical to know that. The last thing that I'd mention that I think is something of national importance, we have very few facilities in Kenya that can actually deal with these cardiac emergencies. Very few. As I speak to you, for example, we have practicing cardiothoracic surgeons in this country are about 16. 16.
16
Literally,
only?
16.
The entire country?
We have got a population of 55 million people.
Yeah.
So you're talking of about one cardiac surgeon for a million people.
Where are we going wrong?
So
is it that
not a million,
not
actually, for 5 million when you think about it.
Is it that we're not having people who go for these courses, or they're there, but where are we going wrong?
So there are a number of aspects to it. The first one is a lot of the bright young Kenyans, doctors in this country, they really want to serve this nation, but they are frustrated in this country. There are no employment opportunities. They go elsewhere. Before this year, last year, I was working in Australia in a cardiac unit. The pay is better. The work environment is better. You're really appreciated as a professional. When you come back home, professionals are just not treated right. The investment in healthcare, literally, if you suddenly have a heart attack in Lodwar today, or you have a heart attack, even if you're a prominent person, you've gone to visit your constituents in Wajir right now and you have a problem, and you've got probably an hour or so opportunity for intervention to be done, you will not get it. Apart from Nairobi, Mombasa, Eldoret, Kisumu, Nakuru, there are no other places that have got the full complement of cardiologists and cardiac surgeons that will be able to help the people. So I think investment in health in this area is really, really critical.
That's really sad to know. And the amount of brain drain, especially in the medical field, is immense. You know, I know more than 5 people who studied medicine here, but they are working abroad. What should the government maybe do, according to you? What can be done to reverse this?
That's one of the pains of my life, because I made a very tough decision when I was thinking of coming back home. And I talked to many of my colleagues, and everyone was wondering, why are you going back?
Yeah.
Yet if you think about it, if we don't serve our people, then who will do it? At some point, we have to make that decision to serve our own. We as Africans have to sort Africa's problems. But specifically to your question, the investment in healthcare that the government needs to make is known. it's not coming, it's not reinventing the wheel. It is known. There was the Abuja Declaration where certain percentage of national budget was meant to go to health. That is known. If you go to the Ministry of Health right now, in their shelves, they have got a lot of policy documents that are really good, but they've never been implemented. We are doing things in a very uncoordinated fashion. Every county wants to have a referral institution that is not at all related to the facilities around. So we're thinking, can't we have region, maybe centers of excellence that are regional, so that we say if you have a kidney problem, in Kenya we know this is the place you go to. If you have a heart problem, this is where you go to. But everybody is doing their things uncoordinated. Then lastly, these young doctors who are coming out of our facilities and are staying unemployed, and it's a great pain. They want to serve Kenyans, but they're staying unemployed. After a few years, when they get opportunities to go, you can be sure they'll never want to come back. So I think investment not only in buildings, but investment in people, because at the end of the day, it is people that get the job done.
Yeah, it's really a sad state. And you mentioned that there are places, if someone gets a particular heart condition, probably a heart attack, they may not be able to get help at all in time. So is there any maybe first aid that one can, if there's someone in the house with them, is there something that one can do before one gets to the proper facility?
Yes, so generally speaking, there is what we call first responders, or the first people that get to someone if someone has collapsed. There's a certain protocol that the general public, it's good for them to know. So in many countries, the general public is trained in what you do as a first responder. So this, what we call first aid, the general public knows. In fact, there was a patient I remember who collapsed in a train station, and within 1 hour was on my theater table. The members of the public are the ones who did what we call the CPR, cardiopulmonary resuscitation, members of the public. So it is beyond the scope of this interview to explain how all that is done. But now we have agencies in this country, St. John's are doing it, Kenya Red Cross are doing it, so that it's good for members of the public to be trained on how to do basic resuscitation in case somebody collapses. It might be because of a cardiac thing, it can be because of a brain thing, but it's important for them to know that generally. But beyond that, I think it is important for us as a country to invest in a number of facilities that are distributed across the country that can then meet this critical need. After somebody is brought in as a casualty, how then are we able to sort them beyond that? And that is where the big failure is in our system.
Okay, let's get into the treatment options now, the solutions to all of this. What are the treatment options available to the various cardiovascular problems that you've just talked about?
Again, it goes back to the specific problem that we are referring to. There, in the congenital group, there are some of these that some medications can be given and the child is allowed to grow, and some of these, especially, quote unquote, holes in the heart, there are some that can close on their own over a period of time. So there are some medications that are given and then the child is followed and observed, and there are a few of those that close over time. So then there are medications that deal with the heart failure. So somebody might be having a congenital problem and has heart failure, so medications to handle the heart failure. But the structural problems that these patients have can only be sorted by surgery. And that is the big elephant in the room, because one cardiac operation, the cheapest you'd find anywhere in the world, costs at least 500,000 shillings. Anywhere in the world. The cheapest you can find, anywhere in the world. So you have a lot of these congenital problems that occur in the poorer populations. And then they're the ones expected to be able to foot these bills. So a bill of $1 million, $1.5 million, to get a hole in the heart closed. A lot of people just cannot afford that. And yet, structural problems can only be handled that way. The cardiologists have got some what we call minimal invasive techniques that they can use, like through the blood vessels to close some of the holes. But again, the issue is cost. When it comes to the older population, so rheumatic heart disease, again, surgery, open heart surgery. And in this country, I work in Tenwick Hospital. It's the place that does the highest number of open heart operations in the country. It's a mission hospital. It does more than our national hospital, which to me doesn't make sense. We must invest in our national facilities in building capacity to be able to help the people at need, because rheumatic heart disease, a lot of it again requires open heart surgery. Coronary artery disease, the same. It's either the cardiologist putting in a stent or we people coming in and doing what we call coronary bypass surgery, which do cost. And so investment in health, we've been talking to NHIF. NHIF covers 450,000 shillings for every open heart operation. Okay. So if a patient needs to pay, for example, 1.5, is a poor patient, they've been paying the NHIF faithfully, but NHIF only covers about a third at most of the cost. So then what happens? I lastly say this because this is very emotive for me. I have a list of patients who are waiting surgery, and when a patient dies on my waiting list, they color code it red because they have died waiting for surgery. They don't have the money to get the surgery done. So every time I look at that list and I see more and more and more reds, because the patients can't afford. For me, it's very depressing. It's very depressing, given that the reason I came back to this country, I felt that probably many of us can join together and make a difference in our patients' lives. And when there's surgical correction that can literally save the patient's life, it can literally cure the disease. And the only reason somebody is dying is because they cannot afford. That is gut-wrenching for a doctor.
I can imagine.
Yeah.
So the only treatment option is open heart surgery for most of them?
For many of them, it is. So if somebody has a structural problem, like when you talk of rheumatic heart disease, there are valves in the heart that are usually affected. So you might find this valve becomes very tight, so blood is not flowing through properly. Unless you treat that surgically, either repair the valve or replace it, you'll never be able to help the patient. They can be given medications over time, but the structural problem remains. And then the heart gets weaker and weaker, and the patient dies on. Cardiologists, there are certain interventions they can do, like they're what we call balloon valvuloplasty, so it can help some of the valve problems. But again, it goes back to the cost. But ultimately, for many of our patients with congenital problems, if somebody has a hole in the heart, it needs to be closed up. If somebody's valve is either leaky or too tight, it needs to be repaired or replaced. If somebody has a coronary artery problem, they either need a stent or they need bypass. And all these are open heart procedures that cost a lot of money.
I get that. Now, for someone who's looking after a patient with cardiovascular, some of these cardiovascular diseases that you've just mentioned, do you have maybe a word of advice to them? Is there something that you would want to say to them?
Two things. The first is I want us to make some noise because unfortunately in our country, if we don't make enough noise, the policy makers or the people that hold the coffers are not moved. So the people that have patients back at home, make some noise, talk to your leaders, your MCAs, visit their offices, knock in the office of your governor, let them know that this is a problem. Because a lot of Kenyans, if I ask them when they heard about rheumatic heart disease, many have not even heard about that. Yet I can tell you, every day there are Kenyans dying of rheumatic heart disease. I have a list of thousands of patients waiting for surgery specifically for rheumatic heart disease. So please, let's make noise. Let us engage the powers that be so that people understand that this is a problem that needs political, economic intervention. But second, know that you're not alone. There are many other people who are faced with problems like this, and we have organizations in this country that seek to help people like this. We have the Kenya Cardiac Society that is doing a fantastic job in engaging both government and in helping patients, in engaging industry, pharmaceuticals, to make things, drugs cheaper. Then we've got many other agencies. We've got like the Matter Heart Foundation that is helping a lot of kids that need. We just started what we call the Maseki Heart Foundation, named after the young man that died and inspired me to get into medicine. So there are all these foundations that seek to help. So you're not alone. If you seek help, you definitely find help. But lastly, when you have some symptoms, or when you notice some of these things at home, a child just getting tired, squatting, just doesn't seem to keep up with the rest, please let these children be checked up. Because if you can have earlier diagnosis, our chances of cure are much higher than when you have late diagnosis.
All right. How do we spread awareness to this? You know, something like what you've just mentioned, like a child who's squatting as much. I'm sure that many people didn't know about that, you know, on what to eat, what not to eat. How do we make sure that we're spreading enough awareness, and maybe who is responsible to do that?
So the Ministry of Health in 2018 came up with a policy document. They called it the Cardiovascular Diseases Guidelines. So this is a policy document that is really informing to the level of the community health worker some of the things they need to be doing in the community in terms of awareness, letting people know. For example, now the community health workers are going in people's home. They're doing blood pressure checks, ensuring that people are taking their medications. So I think from at a policy level, there's a document that is helping push for that. However, I feel at individual level, as citizens of this country, we need to take this responsibility at a personal, individual level to supplement the efforts that the ministry is making. And so many of you who are listening to this, you know people in your environment who have symptoms of this nature. Let us help one another. Let's educate one another so that together we can have a healthy country.
All right, and as we wind up on this particular discussion, the theme for this year's World Heart Day, which was celebrated last month on the 29th, was Use Heart, No Heart. Could you get us a bit into that?
Yes. So we did a celebration of the World Heart Day, and the idea really is to involve people to move more, because we've realized a lot of the problems that we are currently having is out of sedentary lifestyles. We actually now say that sitting is a new smoking, meaning the impact of smoking on health is now comparable to the impact of sitting on health. And so we want people to use their hearts more, meaning move more, really be thoughtful about your level of activity. Many of especially in this city of Nairobi, people have these little devices that you put on your wrist, the smart watches. You can literally be able to know the number of steps you've taken in a day. And so there is a way you can say, have I moved as much as I should? 10,000 steps, we've said that is a good starting point. So it's possible to actually measure. There are metrics. So every 30 minutes, like for you guys who do work that involves a lot of sitting, every 30 minutes, break your sitting. You can do lots of, if you need something in a different office, walk to that office instead of calling. So there are practical ways. If instead of using the lift, just walk up. So that level of intentionality, when you have it, you can actually start to move more, use your heart more, and that way you have a healthier heart.
Thank you so much. This was so insightful. I have personally learned so much on heart diseases, and I believe that our viewers at home have also got to learn a thing or two from this. If I may allow you to give your parting shot as we wind up.
Sure. The last thing that I'd like to say to our viewers, we can actually change the story of heart disease in this country together. I'm really convinced that if we work together as a unit, we can make a big difference. Those of you who have ability, you do the Matter Heart Run, contribute. Those of you with a bit of knowledge, engage the people around you. But most importantly, those of you who are in positions of power, our governors, why don't we invest in healthcare? The Ministry of Health, the public officials, why can't we change the story so that Kenya becomes a model for the countries around of what is possible when people come together to sort out heart disease?
Oh, I got that. Thank you. Thank you so much to each and every one of you who has been tuned in on the show. This is where we end. Good morning, Kenya. Do enjoy the rest of your Tuesday. We'll meet again tomorrow, same time and place, God willing. I have been your host, Vivian Dagwa. Goodbye.